to move on to our next honorable speaker. So our next speaker is Professor Nishkarsh Gupta. He's professor at the All India Institute of Medical Sciences, New Delhi. He has over 200 publications to his name and 20 book chapters. He's the chief editor for the South Asian edition of Barash Clinical Anaesthesia and a section editor at the Indian Journal of Palliative Care. He has reviewed many PubMed index journals, and his main interests include airway management, skill training, onco-anesthesia, and ultrasound-guided regional blocks. Dear all, it has been an honor and a privilege to introduce our esteemed speaker tonight, and I think it's an even bigger privilege for the hundreds of our viewers to be able to benefit from these sessions by our experts from the comforts of their home. I think this is one of the very few things that have come out good out of this terrible pandemic. Now, without further wait, I will hand over the mic to Professor Nishkarsh Gupta, who will share his experience about the role of ultrasound in airway assessment. Professor Gupta.
Thank you, Mumtaz, for the kind introduction. First of all, I'll thank SAT for giving this opportunity. I am working in Department of Onco-Anesthesia and Palliative Medicine at IRCH AIMS. It is basically an exclusive cancer center. So now will be. So sorry for the initial hiccup. So basically, I'll be discussing about dynamic assessment of the airway and role of point of care ultrasound. Ultrasounds have been introduced in practice of medicines as early as 1940s. At that time, they were big, huge machines. And now we have small point of care handheld devices. And the practice has changed from being dependent on radiologists to kind of a stethoscope for every clinician. So they have part and parcel of our day-to-day activity. And nowadays, big role of ultrasound is coming in assessment of the airway as well. So I will be covering my talk under the following heads. I'll be discussing about the role of ultrasound in airway assessment. How do we mark the cricothyroid membrane? The preparation of awake intubation. How do we confirm endotracheal intubation? Confirmation of the DLT insertion and assessment of the vocal cord movements. So all of us know airway management is, you can say, bread and butter for anesthesiologist, and a lot of airway assessment parameters are available for all of us. So we have, all of us know about Mallampatti class, the basic one, the modified Mallampatti, the thyromental distance, the sternomental distance, the mouth opening, jaw protrusion, and a combination of these like Wilson score or Algronzi score. So the list is endless. And we have, all of us face that we have, once there have been situations when we assess the airway, we find it normal on assessment and end up in a difficult airway. And the other side of the coin, we assess it as difficult. So we have a patient with Mallampatti 3, thyromental distance, sternomental distance, all distances are less, and eventually the airway management is easy. So what I'm trying to say is all of the currently available parameters, the sensitivity, specificity, and positive predictive value is not up to the mark. And we are still left in a lurch that what to do despite the availability of so much of tests. Moreover, in some situations, like you have neck contractures or some intraoral cavity mass or reduced mouth opening, you may not be actually able to correctly assess the airway, because it all depends upon the structures visible when you open the mouth, ability to protrude the lower jaw, neck movement. So those things cannot be accurately assessed because of the anatomical difficulties. So basically, the conventional methods are not very reliable, firstly. Secondly, they do not provide us the dynamic assessment. So there is a one-point assessment of the airway, and they do not provide us the dynamic assessment with respect to the airway. Ultrasound, all of us know, basically we have an ultrasound machine, we have the ultrasound probes. So there are many of the machines, many probes. Broadly, important thing about ultrasound is you need to know about the patient, the probe, and the presets. So whenever you open the machine, you will have to enter the patient data so that we can save the details for further use. The most important thing is the right probe for examination. So broadly, for practical purposes, you have a linear probe and you have a curvilinear probe. So we can see the frequency also. The linear probe has 6 to 613 hertz. So frequency is higher as compared to the curvilinear probe, which is 2 to 5 hertz. For practical purposes, a lower frequency means higher penetration of the ultrasound beams. So basically, for deeper structures, we use a curvilinear probe. So when we talk of the airway anatomy, the deeper structure is the tongue, so it is a little deeper. So we use a curvilinear probe for this. And for superficial structures, which are more frequently used, like cricoid, the cricothyroid membrane, epiglottis, vocal cords, all these structures are basically visualized using a linear probe. So we have to choose the right probe for the examination, because if you use a curvilinear probe for superficial structures, we'll not be able to see them properly. And we have to select the right examination preset. What is a preset? Preset is basically a cheat sheet. So there are set parameters on ultrasound machine, the gain, the depth, and those things, and they are optimized for a particular kind of structure visualization. So, if we select a proper kind of preset, so the visualization becomes much better. So these are the structures which are usually visible. So you basically assess the width of the tongue. We use or the cross-sectional area of the tongue or the cross-sectional area of the mouth. So these are used basically with the help of a curvilinear probe. We view our transverse or a mid-sagittal view depending on the structure visualized. And basically we have to see the distant points on the upper surface of the tongue and the area of the tongue measured. Then we have the mento-hyoid distance. We need a curvilinear probe, and we measure basically distance between the hyoid and the mentum. Then we can do the AP thickness of the geniohyoid, which we use a linear probe, and skin to hyoid distance, we use a linear probe. So basically, depending on the structure, as I told, we use the probe. The important thing is that ultrasound beam, basically, they will pass, when they pass through the structure, there will be reflection, there will be refraction, they can be scatter, and there can be an obliteration. So these are the things which occur, and some of the rays may pass through and may be transmitted. So depending on the tissue density they come across, you will have various patterns which are seen. So these patterns will help you identify the structure if you know the anatomy. So the important thing for any ultrasound guided assessment, including the airway, is the sound knowledge of anatomy. So to revise the anatomy, basically we know there is a hyoid bone, then we have a thyroid cartilage, then we have a tracheal rings, and in between we have the hyoid. Between the hyoid and the thyroid is the thyrohyoid membrane, and between the thyroid and the cricoid of the this is a complete cartilage. So we have the cricothyroid membrane. I'll be coming to the importance of these structures later. Then we have the nerves. We have the superior laryngeal nerve and the artery here. And once the ultrasound beam is interacting with any of the structures, so depending on the density of the tissues, you may have the structures visible as different shades of white and black. So cartilage generally appears hypoechoic or dark on ultrasound, whereas bone appears hyperechoic or white. So difference in acoustic impedance between the soft tissue and the air. So earlier we used to think that air is an enemy of ultrasound, and so you will not see anything, and the lung ultrasound, the airway ultrasound was not very popular 5 years back. But now the people have realized that because of the air, we have air mucosal interface. So when the air and mucosa are there, so there's a lot of light, a lot of air. Because of the air, the ultrasound beams get reflected, and we have a hypoechoic or a bright appearance on the air mucosal interface. So this tends to help us in identifying the important structures, and especially along the anterior border. Because of the air, the ultrasound beam cannot pass through the tracheal lumen, and so we do not see the posterior tracheal wall. So this is an important thing that you have to understand. Why I'm stressing on this is because you have to understand the anatomy before doing any airways assessment with the help of ultrasound, and you must know what basic ultrasound beams are doing inside the body to realize that what structure will appear like what. So broadly, as to reiterate, bone is hyperechoic, cartilage is hypoechoic, and nerves, if any, will be seen as a honeycomb appearance. So now we'll see what is the basic anatomy and how we can see on the ultrasound. So basically, we have, all of us are well versed with this cross-sectional diagram. So we have nares, we have hard palate, we have oral cavity, the tongue. Then this is a nasopharynx. We have a soft palate, oropharynx, larynx. We have a thyroid cartilage. We have a cricoid cartilage and the tracheal rings. And this is the trachea in between. Behind the trachea is the esophagus. And we have a big floppy epiglottis. So these are the important structures of the airway which we may be interested in. When we take a cross-sectional image of an ultrasound, what we see is M is basically the mentum or the mandible part. Then we have the tongue. Then this is the cross-sectional area of the tongue. Then we have the distance from the mentum to the hyoid bone, mento-hyoid distance. Then we have, this is 3 will be the from the skin to the hyoid bone, the distance from the skin to hyoid, distance between skin to the epiglottis. This big structure is the epiglottis. Then distance between this 5 is basically soft tissue thickness at the level of the thyroid membrane. Then we have the skin distance from the skin to the anterior commissure to the vocal cords. Then from soft tissue levels at the level of thyroid isthmus. And then we have soft tissue at the level of suprasternal notch. So we must always keep the anatomy in the mind, and at corresponding levels, depending on the level we page the ultrasound, we'll see the structures and we can measure those distances. And all of us know that if we have a very thick neck, we have fat structures, so we may not be able to visualize these structures, or if this distance is increased, you expect a difficult airway. So this adds to the value of assessment, and the best part is it is bedside and very dynamic. So it is very, very useful to plan the things in the structures. And another important thing is that there are 2 important ways of doing ultrasound. So mostly we do it transcutaneous. So we place it on the skin in this area and in the neck. Or you can do it sublingual also, but not commonly used because it is little difficult and it doesn't add much value to the assessment which we are doing. Okay, so now coming to the next structure. So the important parameter which has been assessed is tongue volume. So for this, you can either place the thing, the ultrasound probe, we use a curvilinear probe, you can see that. You can either place it in the mid-sagittal or a transverse plane. And this is the tongue volume you see. You can mark it and you can actually calculate the volume. So as we know that a large tongue or a macroglossia can lead to a problem during intubation because you need to do a laryngoscopy, and if the tongue is very large, it may be difficult for you to basically maneuver the tongue in the oropharyngeal space, and it adds to the difficulty in visualizing the larynx. So a large tongue volume may be associated with a difficult airway. So you must know it is a very simple kind of thing. So just place the probe in the right plane and you will see the structures. Only trick is that you must know what structure pattern you see will be what structure depending on the anatomical location. So that you must know in your mind. Another important thing is the preepiglottis space. So basically we can see that we place the probe, which is the linear probe, and the area, and then we tilt it to see the epiglottis. Then from that, we calculate the ratio of preepiglottis space to the distance between epiglottis to the midpoint of distance between the vocal cords. So basically this is the epiglottis. So we have the preepiglottic space, and then we have the epiglottis to the distance between the epiglottis to the midpoint of the vocal cords. And the ratio of this distance has been shown to be very sensitive, up to 85 to 87%, and a good specificity. And they show that if it is also correlated good with the CL grading. But the study which they had done, the number of patients were less, and so we could not have a very good recommendation. But yes, if last studies are needed to further validate the findings. And if there's a decrease in distance from epiglottis to the vocal cords, the overall difficulty in laryngoscopy is expected. So if this distance is less, so you have that less overall distance available for maneuverability of structures and the tongue is less, so overall possibility of difficult intubation will increase. So basically this is the preepiglottic space and this is the epiglottis, and then we have from epiglottis to the vocal cords, and the ratio of these two adds tells us about the difficulty of possible laryngoscopy. Then important another structure is the anterior neck distances. So we basically measure the distances between the skin and the hyoid bone, between the skin and the epiglottis. This is the epiglottis, and between the skin and the vocal cords. So basically 3, 4, and 6. So these are the three distances. And if you have a lot of fat here, you may not be able to actually visualize the structures. So absence of visualization of the hyoid bone is also one of the good markers of difficult airway. And anterior neck distances at different levels might also be related to the airway morbidity during laryngoscopy. So these are the structures which we see. So you can see if it takes some time before you identify the patterns and actually correlate with the anatomical structures. But believe me, it is not difficult. And if you do in 10, 20 patients, you will be able to pick up the patterns and measure the distances. And this was a good article which basically correlated the preoperative difficult airway prediction using suprahyoid and infrared ultrasound measurements in anesthesiology. And so basically, it reiterated that ultrasound is important for anesthesiologists and you need to measure these distances. So broadly, they said basically reviewed the articles which were published. And so the anterior neck distances basically to vocal cord distance basically they did in 50 to 60 patients, and they one author said it was a good and easy, it could easily discriminate between easy and difficult laryngoscopy. However, one of the others was not very sure, and they said discrimination of between easy and difficult was not very clear. Then we have hyoid mental distance ratio. So they did in obese patients, 12 of them, and good discrimination was found between easy and difficult intubations. Then again, we have anterior neck distances, basically soft tissue thickness neck of the level of hyoid, epiglottics, and the vocal cords. And the cutoff values were between 1.1 to 1.28 and had a good sensitivity and specificity. And so the list is endless. So the only thing important here is the number of participants in these studies has been very low. So there have been handful of studies, and that to about 20 to 100 patients, mostly depending upon the study group. So overall, you need. So parameters basically were done in only small number of patients. Then they have not been measured by standard techniques. So all of the authors have their own way of doing things. So the technique has not been standardized as of now. So you can see the slight variability in the measurement cutoffs that these authors have reported. Then all said and done, ultrasound is a user-dependent kind of thing. So you see something, other person may not be able to see those structures. So a lot of skill is involved initially, and it will depend upon the user. And so we need training and patient selection. That's why we need to see the patients, initially try to have patients who have good anatomical landmarks to be able to visualize the structures better. Another important thing which basically troubles us is the size of the ET tube in children. So many of times we have felt, especially in a smaller children, we have used a formula to calculate the size of the tube, and you end up selecting a tube which is either too small or either too big, and eventually you have to do a re-laryngoscopy to intubate the patient. So basically this is a challenge, and we need to find better ways. So ultrasound has come up in a big way. So they have found that the minimal transverse diameter of the subglottic airway basically helps to gauge the appropriate size of the tube. So they basically said that if we measure this diameter, then we may reduce the reintubations in the patients especially in children. Then another important issue is that when you are intubating, especially in emergency situations, you may not be able to appropriately judge whether the intubation has been done properly. We all of us know capnography is gold standard and it mostly helps us, but sometimes in some critical situations, either you may not have it or you may be having a false reading. So in patients with cardiorespiratory arrest, low flow states, if there's a bronchospasm or there's a technical malfunction, capnography actually may not be of any use. So if we use an ultrasound, we may be able to confirm the endotracheal tube. We can use a transverse and a longitudinal image of the ETT in the tube. You can see this is this two lines here and here. So this is the transverse and this is the longitudinal image, and we can see that a double track sign is seen if the tube is in the trachea. So basically what is recommended is to use a tracheal rapid ultrasound examination and in the suprasternal notch window. In the window, we will see the esophagus and the trachea. And when we see the tube passing in, we can see whether it is in the right place and we can confirm the placement. I will be coming to this in the later slide subsequently. Even the ACLS guidelines have recommended that we should use ultrasound if possible and the skill is available for confirmation of the ETT in the cardiorespiratory arrest situation. To take it further, so we discussed that we can confirm using ultrasound the placement of the tube. So we can see we place the ultrasound probe, the linear probe, just to the left of midline in the suprasternal notch. Then we can see the trachea. We can see the thyroid gland. This is the carotid artery, and we have an esophagus. This is a muscular structure, usually collapsed and may not be visible. To identify, you can ask the patient to swallow and you can see the movement here, or if there's a Ryle's tube, you can see a small dot here. So when you perform the transverse scan above the sternal notch to visualize the trachea. So at this point, one of the assistant will keep the ultrasound probe and be ready. So you anesthetize and intubate the patient. Now we have three possibilities. Either we see the tube in the esophagus, so we can see a double trachea sign. So you can see another rounded structure to the right of trachea, to the left of trachea here, or you can see tube inside the trachea like this. You can have a double tract or double lumen sign, or tube may not be seen. So if it is, so the negative finding is more important. If the tube is not in esophagus, so it is in trachea. Secondly, and then you can see the double trachea sign also in the trachea. There is a small video, I'll be showing this. Suppose the tube is not seen, then you will have to confirm the intubation using a lung sliding, which is placing the ultrasound probe in the chest wall, and you see the movement of, you ventilate through the tube and you see the movement of the lung to confirm the tube is in place. Another important thing is when you are placing the tube within the trachea, you may see the movement of the trachea. I'll be showing you on the video. And as this I have already told, so in the esophagus, you will see a double trachea sign. So you can see, so as the tube is in place, you can see the movement of the tube in the trachea, and you can see these reverberations which are there because of the tracheal tube, endotracheal tube being placed into the trachea. So please this is the view which I am again reiterating because this is one of the most common use of ultrasound for airway management, and it has been recommended also. So this is the view we should be targeting, and you will be able to confirm the tracheal tube placement. Now, another important use of ultrasound is that we have a lot of difficult airway, and many times we will have to prepare the airway by giving ultrasound blocks. So we can give a transtracheal block or a superior laryngeal nerve block. For that, we generally done blindly, but we can use it. We can do them using an ultrasound. So we can identify the hyoid bone using an ultrasound by placing the linear probe here. And then we can see this structure, this classical structure, hyoid bone is usually seen. It is easy to see. And we can identify the cornus and we can deposit the drug here. And the success rate has been shown that success rate of the block increases immensely if you use an ultrasound to give a supralaryngeal nerve block. Then after tracheal tube confirmation, the second most important use of ultrasound is to identify the cricothyroid membrane. All of us know that in a difficult airway, cricothyroid puncture is the technique for rescue. So you must always, all of us should know the technique of cricothyroid membrane puncture. But many times it becomes difficult to identify the cricothyroid membrane, especially in those with thick neck and they have a lot of fat tissue, or the neck is having some kind of radiotherapy or some burns conductor is there, and you may not be able to identify the cricothyroid membrane. So for that, we need to place the linear transducer transversely over the neck. You have to place it transversely over the neck, just above the suprasternal, and then we see the trachea. So we can visualize the trachea. Then we have to move the transducer to the patient's right, and then you have to rotate so that in this direction, so that we get the longitudinal scan. So this is the longitudinal scan we will get. Then we have to visualize it and move it cranially till we visualize the cricoid cartilage. Now, important thing is, how do we identify the cricoid cartilage? So when we are moving the ultrasound probe up, so you can see this is the pearl of sting appearance. These are the small tracheal rings. Then as you go up, there is a large bump up. There's a large cartilage, and you can always see there is a double shadow to it. So this is the cricoid cartilage, and this is the only complete cartilage here, and this is the largest of them. Beyond the cricoid cartilage is the cricothyroid membrane. So we have a cricoid cartilage, then this is a cricothyroid membrane, and we have a thyroid cartilage. So we can always mark it with a pen during an ultrasonography, especially in patients with a difficult airway. And this mark can help us do a quick puncture of the cricothyroid membrane in case of emergency. The recommended technique for CTM puncture is the scalpel bougie technique, for which we need a scalpel, 10 blade, then a bougie, and a size 6 tube. So all of us must be aware of this. This is a rescue technique for us, like a stepney of our car, and we should not falter on this. And we must practice this as far as possible, as many times as possible. Then another important thing for ultrasound use in clinical practice is the vocal cord movement. So you can place the transverse probe here, just above the thyroid cartilage, and we can see the vocal cords. So we can visualize the structures. So we have the arytenoid cartilage here, then we have the vocal ligament, then we have the thyroid cartilage, and then we have the sternocleidomastoid muscles. This is the classical view of the vocal cord. We can ask the patient to phonate, and we can see the abduction and adduction movements. And the important thing is that we should always have a pre-anesthesia visualization of the vocal cord. We should see what is the range of motion, how much the vocal cord is moving, and what are the structures which are visible. And then a post-anesthesia scan can help us judge the readiness of the patient to the basically extubation, or if there is a thyroid surgery, whether there is any change in the vocal cord movement, whether to assess the recurrent laryngeal nerve injury. So those kind of things become very important, and it is an important tool for us for dynamic assessment of the airway. So I deliberately kept it short because I just wanted to focus on the practical aspect. So to summarize, ultrasound is basically a good tool for real-time dynamic imaging for various structures in the upper airway. It helps us to identify possibility of a difficult airway, helps in securing it and also maintaining it. It has now challenged the classical approach of clinical assessment, and the time is not far that it is a standard of care rather than a novelty. And all of us probably will be having an ultrasound probe in our pockets in times to come for doing all kind of assessments on managing the airway of the patients. As of now, the problem is that there are a lot of promises there, a lot of structures which can be identified, a lot of parameters which are there. but the true cutoffs are not clearly defined for most of the parameters, probably because we have only small studies measuring, having very few hundreds or few less than 100 patients, and the way of doing it is not standardized. So for Mallampati, all of us know, like one of the most commonly used parameters, we know how far the patient should sit, what is the mouth opening of the patient should be, what he should protrude the tongue, he should not phonate. So those kind of cutoffs, the kind of parameters which we have crystallized for normal airway assessment parameters, for ultrasound, it is still not there. And so in times to come, maybe another few years, we will be having large sample studies, and that will help us to further assess and help us to make it a gold standard for airway management. So that was my last slide. And at the end of the day, it is a good quote say that the goals are simple. For anesthesiologists, there are two goals. So one should be secure and one should be safe. So safety of the patient is very, very important. And this is the key for us in managing the airway. Thank you all, and I can take questions.
Thank you, Dr. Nishkarsh Gupta. I hope to say right your name. If I not, I'm really sorry for the enlightening and amazing presentation. We have some questions from our audience. I will start, first of all, with the question of from Fatma, Dr. Fatma Gohar. Ask if ultrasound can give idea about subglottic stenosis, especially in children.
Yes, basically, ultrasound will help us to tell the area of the subglottic measurement can be done, and we know the normal measurement. So below the normal measurements, the cutoffs, the subglottic stenosis can be predicted. To some extent, it is possible, but the only thing is that children generally are not very cooperative. For an airway assessment of ultrasound, using an ultrasound, you need a cooperative patient, because you will have to put a probe on the neck, and the child has to be very cooperative.
A second question is from Dr. Mohammed Soliman. He asked if the endotracheal tube is just at the inlet of the larynx. We will not see, however, the lungs could be inflated. What is your comment?
So it is an interesting query. So if we place that, so as I earlier told, the assessment of confirmation of tube using ultrasound, you need two people. One person has put the ultrasound probe at the sternal notch, just left to it, and has got that view in which we see the trachea, the thyroid cartilage, and the esophagus. So that view is in place. So once you trachea, we only inflate the lungs with the endotracheal tube only after that we have placed the tracheal tube. So once we are introducing the tube, we can pick up the tube, whether it has been seen in the esophagus, you can see a double trachea sign, or it has passed the trachea, or the third possibility is you may not see the tube at all. So the important thing is that when we are inserting the tube, we know the exact length. So that reasonable estimate we have. So for adults, say, if I talk of my country, generally for females, we keep about 18 centimeters. For males, we keep about 20 centimeters. So that has to be sure from your side. You cannot just keep at 15 centimeters and say you are in the trachea. So that assessment has been done already. So important thing is when you insert the adequate length, then whether it is in the right place or not. So that will be done with an ultrasound. That can be done by just getting a view, whether it is in the trachea or esophagus. That will be possible. But if you do not insert it adequate length, ultrasound will not help.
We have another question, again from Dr. Mohammed Soliman. He said there is also possibility of false passage, like the bad scenario of intracranial passage if nasal tube is inserted with fracture base of the skull. He wants a comment from you, in this issue?
So if we have a fracture base of skull, we don't do a nasal intubation. So it is an absolute contraindication of using a nasal intubation. So that should not have been done at all. So my comment will be that we should not do that, and it is a real possibility if you use nasal intubation in patients with a fracture base of skull.
I don't see any other question from the audience. For sure, your presentation is amazing. The use of ultrasound to quiet and assist clinical airway management has potential benefits for both provider and patients. The issue is to find a way how we can make it more actively involved in our daily clinical practice. Thank you again from your